We'll move on to our next speaker, Dr. Anil Shah. He practices in Nandubar in Maharashtra. He has received a number of research awards and books, and he has published books on SICS. His specialty is SICS in snare bisection, and we'll be seeing his next video in the presentation. Dr. Anil Shah, sir.
Could you share your video, doctor? You have to unmute yourself. You have to unmute yourself, yes.
Unmuted. I have shared my video. Can you see my video, madam?
No.
No.
You have to click on it. Would you want Mr. Sunil to share it?
Yes, madam.
Mr. Sunil, can you share Dr. Anil Shah's video?
Yes.
Mr. Sunil, are you there?
Yes, ma'am, I'm there. I'll just show you.
The video is in with voice, madam. Should I speak or the?
If the voice overlay is loud and clear, then it's okay. Otherwise, you can speak.
Okay. I'll.
Surgery. This is my snare and McPherson forceps.
Okay.
I usually do transconjunctival limbal tunnel incision. It is 3.5 millimeter or 4.5 millimeter depending upon the size of the nucleus. The external incision is smaller and internal incision is wider. It is extended by 2.8 millimeter keratome. This is a very hard cataract. Now here a trisection is done with the snare. Main important thing is that the nucleus must be free floating into the anterior chamber. OVD or viscoelastic must be used. Nucleus should not be attached to any intraocular structure to the endothelium or iris. It should be freely floating and there should be adequate hypotony. Now when the snare is passed, it is passed obliquely. The loop is made smaller to the size of the nucleus. One arm goes below the nucleus and one arm comes above the nucleus, and a clear-cut bisection or trisection is done. The small fragments are removed by McPherson forceps. I use McPherson forceps and it gives a very smooth delivery without damaging endothelium or the wound. This is another hard cataract in which trisection is performed. The nucleus is made free floating into the anterior chamber with the OVD or sodium hyaluronidase. The main advantage of my snare is that when the bisection is done, the loop becomes smaller. So it is away from the endothelium and it is away from the posterior capsule. So it doesn't cause any damage to the posterior capsule or endothelium if it is done properly. Snare should be avoided when there is a hard eyeball, when there is a positive pressure, when nucleus is not free floating, and when the patient's eye is moving, and last is when you are not confident. It is a very safe technique. It can be used as an alternative to phaco and other methods of manual small incision cataract surgery. You get a very clear-cut longitudinal division of the nucleus, so it can come out to the smallest incision. This is a rock hard cataract, black cataract. Such type of cataracts are very difficult to manage with phaco and also other methods of SICS. But with the snare, you can see that the clear-cut bisection and trisection is performed. Here, the main important thing is that you get a clear-cut bisection. The posterior plate of the nucleus is totally broken easily. The loop bisects the nucleus so smoothly that it is just like a knife passing through the butter. Another important thing is that my snare is a bimanual technique. So there is a rock steady hand movement and there is no jerky movement in the while dividing the nucleus, so it doesn't cause any damage to endothelium or posterior capsule. With this snare, you can also perform a premium IOL, multifocal IOL also, because the incision size is 3.5 millimeter or 4.5 millimeter, so it doesn't cause any changes in the astigmatism. See, this is an intumescent cataract which is divided into 3 sections, and it has been removed through a small incision of 3.5 to 4 millimeter. Simple practice is important. If you do few cases, then you will definitely master the technique. And my snare can be autoclaved multiple times till the wire loop breaks. You can use it. Snare is simple, easy to learn, and it is machine independent, so it saves you a lot of money. Thank you very much for your kind attention.
Thank you.
Very, very impressive surgeries, Dr. Anil. It was very nice to see the different techniques each of you are adopting. So I think because you're using the snare, you like to have your incision smaller, no?
Yes, yes, smaller, 3.5 millimeter or maximum 4 millimeter.
How for a beginner, what would be the tips you would say so that they don't catch the iris and go appropriately and do it? You may not have a well-dilated pupil in all scenarios. If you don't have a well-dilated pupil, would you want to use iris hooks to keep it well-dilated?
It is not needed, madam. If a big rhexis is performed, then if the nucleus is prolapsed into the anterior chamber, then iris hooks are not needed. You can do all these things in the anterior chamber. Only thing is that you have to prolapse the nucleus by doing a big rhexis. Even if you do a capsulotomy also, it is possible to perform these surgeries.
Sir, for beginners, would you suggest to use a glide below your snare so that we can protect the posterior capsule, or it's not required at all?
Not at all required, sir. For last 20 years, I am using this snare. Not a single PC rent is there. Only few cases initially endothelial trauma is there, but with the practice, this is not also occurring, sir.
Because it appears like a blind procedure. The snare going at the back, you cannot see what.
We are putting vectis as also a blind procedure. We are putting fish hook. That is also a blind procedure.
I have a question for Mr. Dr. Saurabh or Namrata or Dr. Debashish, anybody. How does it compare to the my loop which is used in phaco surgeries, the snare? I have actually no idea. I've not used a my loop.
See, I've used a my loop, but the my loop is made of nitrilon and cannot take care of the hard cataracts, the very hard cataracts that Anil showed. And my loop comes from the side. So naturally, it can actually, it is a tool to divide the nucleus within the capsular bag. Whereas Anil's thing is very smart. It's just made of the A1 string of the guitar, if I'm right, Anil.
Yes, yes.
And it's very economical and 220 gauge needles. So the OT assistants, they make it for us. We learned it from Anil way back in 2001-2. He was so kind to come to our hospital. And since then, the supra hards, we do it because, you know, in the supra hards, we were discussing all through this webinar that essentially you have to do a large incision, etc., etc. So you need a very effective way of fracturing the hard nucleus. This Dr. Ravindra's technique is difficult to emulate in a very hard cataract. I mean, just breaking it with the pressure of a second instrument is difficult. So Anil snare technique works wonderfully, only that we need to learn it. There are two things to the learning of this as we have learned. One is that you see the loop and you take it down up to the equator of the nucleus and then turn it. Don't turn it before, because if you turn it before, then you will be hitting the nucleus and the nucleus will have hit the posterior capsule and the capsular bag. So once you go it goes round like a lasso, and then you slowly just pull it. It gives you the fear factor out of which Satyajit recommends that you put a sheets glide and all that, but nothing like that happens. Just keep your left hand support of the snare, and I think that does the trick. And the second thing is that a nucleus that hard is going to be 4 or 5 millimeters thick. So the lasso ring also has to be open to that amount. So you cannot have an incision less than that. So people try to go very small or something like that. And if you have a small nucleus, then it won't go. And if it doesn't lasso the entire nucleus, then again there is a chance of hitting the capsular back complex. So these are the two things that we've learned from Anil.
Thank you. Any other question,
yes,
Dr.
ma'am.
Saurabh? Yes, Dr. Mehboob.
I just had the experience of using a snare a few months back, and I learned a few things. And the most tricky part is introducing the snare. That is the most tricky part here, because it has to be introduced in a slightly oblique manner and then hooking it. So when you're introducing, the titration of the opening of the loop has to be manipulated with both your hands. So that is the one learning part. Otherwise, it's very easy. The more bothersome part is the endothelial touch when you're trying to introduce the nucleus will be pushed against the corneal endothelium. So these are things when you just have to make 10 cases would take for you to learn. And the fundamental difference between this and the MyLoop is designed for in the bag usage, as Sir Test told, whereas this is predominantly for an anterior chamber usage. But the biggest advantage is the cutting is effortless. The cutting is absolutely effortless. There's no mention of any hardness is required in this case, because all cataracts behave the same way here. Only thing is hooking the nucleus is a challenge that has to be learned.
That is to be learned, definitely, sir.
Thank you very much. Nice.